So what I'd like to do right now, just quickly, is to introduce our speakers and moderator and to thank them for participating. So our plan is to have each of the speakers speak for about 20 minutes, and then we're going to have time at the end for questions and answers. And then at the back of the room, you're going to see that there's a table with our literature and information about the legislation and our various programs. So feel free to get literature, get materials on your way out. And there's snacks and water and things back there for you as well. So John Krebsack is going to be our moderator this evening. He is a licensed clinical social worker and a credentialed alcohol and substance abuse counselor with over 20 years of experience in the field. So he'll be moderating and kind of also helping with the question and answer portion of this evening. We also have Gabriel Saya, and he is the director of the Drug Policy Alliance's New York Policy Office. He's going to update us on the status of the medical marijuana bill in New York State. We also have Dr. Sunil Agarwal, and he's a board member of the Americans for Safe Access Foundation, and he's a resident physician at NYU Center in New York City. And he's going to be discussing the current state of medical marijuana research, and then also discussing the parameters for safe use with medical marijuana. And then we also have Dr. Julie Holland, who's a board-certified psychiatrist and author of The Pot Book, a collection of the most up-to-date information and scientific research on cannabis from leading experts. She will provide an overview of the literature on marijuana and psychiatric conditions. And then finally, we have Dr. Andrew Tatarsky, who has specialized in the field of substance use treatment for over 30 years as a psychologist, supervisor, program director, lecturer, and author, and I'm also fortunate to say mentor of mine. I'm very happy to be working with him. He's the director of the Center for Optimal Living and is the founding board member of the Division on Addictions of the New York State Psychological Association. He's the chairman of the Board of Moderation Management, clinical advisor to the New York State Office of Alcoholism and Substance Abuse Services, and is on the board of several harm reduction organizations. Dr. Tatarsky will be discussing the implications of medical marijuana for mental health and substance abuse treatment providers. And I also want to thank those who have been working behind the scenes with me to get this event together, especially Dr. Alicia Mascow, Julie Netherland, Nichelle Horlacher, Alexis Posey, and Tracy Rongovan. So thank you, and I'm going to turn it over to John.
Thank you, Jennifer. All right, good evening, everyone. I'm John Krebsack, and I was pulled into the moderator role, and I'll do my best to be moderate. I just wanted to say that I'm glad that the medical caffeine bill has passed, and so I'm not in any danger of that. And but I primarily see my role as sort of creating a historical framework for what we're going to be talking about tonight. And that's to say that, marijuana was part of the U.S. pharmacopoeia from about 1850 to 1942. And it was prescribed for a pretty large number of conditions. And I think that we're going to get to that later on, because that in and of itself may be somewhat problematic, right? When you kind of say that it's good for everything, it usually raises some eyebrows. But then in the early 70s, under the Nixon administration, it kind of took a turn for the horrific, right? So it becomes Schedule I, and high addiction potential, no medical value, and I think that's one of the things that again raises some eyebrows, right? How does it go from being used by the Chinese and others for thousands of years, and all of a sudden it's there's absolutely no medical value. So I think that what we're trying to do is to find a place that's somewhere in the middle, right? That kind of makes sense. And to that end, I want to kind of mention a couple of things. And one of them is that about 11%, but I guess SAMHSA is saying now 18% of emergency department visits are are related to marijuana. I think that it's, some of it is due to paranoia and various things of that nature. But when it comes to addiction potential, and I see Dr. Holland, who wrote the book, so she's kind of looking at me askance. I'm not sure if all of my facts are right, but she'll be up here momentarily. But I want to talk about addiction potential for a moment, right? Which is a big, big deal, right? So the scale when it comes to addiction potential is cigarettes are way on top, right? So there's this thing that's called the first use folks, right? And so what percentage of people that have used once end up becoming dependent? So with nicotine, it's 33%, and heroin, it's 23%, and then you have cocaine, I believe, 17%, alcohol is 15%. I teach substance abuse policy at NYU and have done so for the last 10 years, so that's kind of why I'm able to remember these. But marijuana comes in at a very low 9%. So that is not a big bad drug in terms of addiction potential, you know. So I want you guys to keep that in mind. And yes, I think that all of the presenters are on the same page, but maybe on different corners of that page, you know, and I think that that's fine too, you know, that I've learned from my mentor a long time ago that you need to be able to hold up both sides of the argument in order for you to be credible. So I hope that we're going to be able to do that tonight, and it gives me great pleasure to introduce our first presenter. And I know he's the first presenter because his slides are up. No. He's not. Gabriel Saya. Come on up, Gabriel. I've known Gabriel for a few years now, and I've had the privilege of having him present my class at NYU, and so you're going to give us an update on the bill. I didn't get a chance to talk too much about the bill, but it looks like this time around, right? We'll see. Okay.
Yeah.
Cautiously optimistic.
Thank you, John.
Thank you, Gabriel.
Hi, good evening, everyone. I want to thank John. His class at NYU, he does a really great thing with his class, which is he tries to integrate into his courses a range of policy issues so that the discussion around addiction and substance abuse disorders, mental health issues, and so forth are contextualized in a broader policy framework, which I really appreciate, and he's invited DPA to participate in that. My name is Gabriel Saya. I work at the Drug Policy Alliance. Some of my team members here were participating in the convening of this forum tonight with Dr. Tatarsky and others, for which we're grateful to be here. I'm just going to speak for a few moments to give a brief update about what's happening in Albany around the medical marijuana bill. There is a bill under consideration right now in Albany. There's a version of it in the state Senate and a version in the state Assembly. This is not new in Albany. Actually, when the first medical marijuana law was passed in California in 1996, that was a voter initiative. New York introduced a medical marijuana bill the following year in 1997. That was introduced by Assemblyman Dick Gottfried, who is based here in Manhattan. He's the chair of the Health Committee in the Assembly. The bill's been reintroduced every year since 1997, and it has been in consideration in Albany that entire time. It's actually passed the state assembly 3 times. Now, each year the bill changes a little bit, so the version that was introduced in 1997 is not the version that's under consideration now in 2013. But it's interesting to note that we've been dealing with this issue in Albany, or the legislature has, since 1997. During that period, after California, 17 other states have passed medical marijuana laws, either through voter initiative or through the state legislature. Illinois, the legislature just passed a medical marijuana bill last week or the week before, sent it to the governor's desk. And a number of other states are also considering medical marijuana laws right now. And it may very well be that this year in New York, we get this law passed finally. But it is by no means guaranteed, and it should not be assumed that because there's all these changes happening in the rest of the country, that anything different will happen in Albany. Albany has a miraculous capacity to be immune to both common sense and to a changing world. And so I think we should be, and ethics, of course, so we should be careful to not assume that simply because there is a vigorous discussion happening at the national level about our marijuana laws, that that's going to change anything here. Just because 2 states have voted to end marijuana prohibition in Colorado and Washington, that may not have any impact on New York State Legislature. Just because New York State is surrounded by states that have passed medical marijuana laws, with the exception of Pennsylvania, does not mean that New York will pass a law. Just because it's the right thing to do, or the science is clear, or it's the moral thing to do, doesn't mean that it's going to pass it. Now, I realize that not everyone in the room may agree with it, and that's fine. You're going to hear a lot tonight about the science. That's not my role. We're fortunate to have Dr. Holland here and Dr. Agarwal, Dr. Tatarsky talk about the science, and then there'll be a discussion point afterwards. But 2 quick points I want to make about Albany and the legislature. Just this week, the bill in the Assembly passed the final committee. It's now on its way to the floor of the State Assembly. That bill is sponsored again by Assemblyman Dick Gottfried. He's the chair of the Health Committee. It's going to be voted on in the Assembly next week. Then it goes over to the Senate. It looks like the votes to pass the bill in the Senate are there, but don't get too excited about that, because if you've paid attention at all to Albany, then you know that the place is not always all that efficient to begin with. And number 2, that common sense measures oftentimes die simply by virtue of the fact that there's a lack of capacity in Albany to do the right thing at the right time. That's why we have an organized effort to pass the law this year. If you're interested in it, there's some fact sheets in the back and a sign-in sheet in the back. And also, if you look around the room, will the folks from DPA put up their hands, please? So that my colleagues there in the back with their hands up are from the Drug Policy Alliance. We're a proud member of Compassionate Care New York. If you have questions about how to get involved, you should talk to them. We have buses going up to Albany to lobby state legislators. Dr. Agarwal was on a call this morning, as was Dr. Holland, announcing that there's 600 physicians who have come out in favor of this law, and that they've joined the Nurses Association and a range of other organizations that are supporting it. One final word about this. I said earlier that not everyone may agree with the medical marijuana law, which is fine, and we'll have a discussion here about it tonight. It's important to note that the medical marijuana proposal in Albany now is not a pro-marijuana proposal, not by any means. And those of us who are supporting it are not and should not be viewed as pro-marijuana advocates, although some may identify as such. This is really a moral issue, aside from the science that you will hear about, aside from the political factors that are at play here. We have a moral issue at hand that is in part on the state level because of what's going on in the federal government. If we did not have a war on drugs, we would likely have done the studies on marijuana. We would likely have moved it out of this Schedule I and into a different schedule. It would likely be regulated at the federal level, as many other drugs are. But unfortunately, the war on drugs has been a war also on science, as much as it's been a war on people. And so marijuana is amongst, or if not the only substance for which there's simply they simply don't allow research to happen on this in many respects. And the one area that they do allow marijuana to be grown at a government facility is widely viewed as inadequate. There is, as John noted, when President Nixon convened a panel led by Governor Schaefer, a conservative Republican from Pennsylvania, back in the early 70s, to look at the marijuana issue, the Schaefer Commission came back and said, you know what, we may not like it, but actually this is not as harmful as has been made out to seem. If you look at the science, nothing is safe ultimately, but this is far less harmful than many other things, and we should remove all criminal penalties for its possession and use. They just put that report on the shelf and ignored it. And for the last 40 years, we've been stuck in this paradigm of the drug war, where today, in the city of New York as an example, the number one arrest the number one arrest in the city of New York is for marijuana possession. The number one arrest, 40,000 people last year, 50,000 in the year before that, 600,000 people in the last 15 years. We as taxpayers have spent $600 million on that. The police have invested 1 million hours in police time. That's simply about marijuana possession. That's not even talking about what the medical marijuana bill is focused on, which is, all right, let's agree that if we all don't want people to even possess and use marijuana, fine. What about allowing people with cancer, HIV and AIDS, and other debilitating conditions to consult with their doctor and, where their physician feels like it's appropriate to do so, use marijuana in a course of treatment that may benefit them and relieve their suffering? That's what this bill is about. And to have that bill get stuck in Albany since 1997 is not just a tragedy, but it's fairly disgusting, frankly, because it means that very real people, New Yorkers, our family members, our neighbors, are left to suffer. They're left to get their marijuana on the street if they will do so, or as many others, they will not break the law to obtain marijuana, and so they live not without access to something that may otherwise benefit them. We have 3 weeks left in the legislative session. The Senate, the Assembly, as I noted, will vote on the bill next week. The Senate has not yet decided on a day that it will bring the bill up for a vote. That means, and the only way that they will really do it is if we get behind an effort to push them and encourage them to do so. So we hope that if you're interested in this issue, you'll sign up in the back and join us in that effort. But beyond that, you have a great discussion, a great group of panelists here tonight that are going to be, they're amongst the top experts, not just in New York, but in the country on this stuff. So we're really fortunate to have them here as locals in New York City and here as panelists this evening. So thanks for the invitation, and we look forward to a good discussion later.
Do you have any sense where the governor is on this?
Yeah, he asked about where the governor was. The governor, when he ran for office in 2010, said that he was opposed. He then backtracked off that and said that he was looking at the issue. And now he says again that he's opposed to it but studying it. So he's maintained a fairly oppositional stance. It's up in the air at this point. If we deliver a bill to his desk, will the governor look cancer patients and family members in the eye and veto the bill? Who knows? It's unlikely. But you know, this was the governor, when years ago, was advocating for significant changes to the Rockefeller drug laws, and he's also been behind or made a proposal to change the marijuana possession law to address those arrests that I mentioned earlier. So it does seem a little strange that he's not come out in support of the medical marijuana bill, but we think that once he has a moment to sit down and read through the science and he hears from patients and their families and certainly from physicians and scientists, that he'll make the right decision. Yeah, if you will hold that question, because I don't want to take up the speaker's time. If you all would hold your questions until the end, and if not one of the speakers, then myself or my colleague Julie can answer those questions. And also, you could just feel free to pull us outside if you like the DPA folks. But thank you so much for the invitation to speak.
And that's these marijuana arrests are at the tune of $75 million per year. That's being spent in New York City. Money that could definitely be spent on some other things. And that was a very good question about the governor. And I think that he's being a politician, right? He's hedging his bets. And I think that if it does pass both houses, then he probably will sign off. So that's my sense. But if it doesn't, then he can say, well, you know, something that he wasn't for in the first place. So, all right. So the next panelist that we have is Dr. Agarwal, Sunil.
Okay. Good evening. It's really great to be here with you. So, my name is Sunil Agarwal. I'm a resident physician at New York University Medical Center. I'm in the Department of Physical Medicine and Rehabilitation. And I also have a background in medical geography. I did a doctorate in that at the University of Washington, and I studied medical cannabis as a health access and delivery system. So if there's time, I'll have a chance to talk to you a little about my research. But what I was asked to do by the organizers today is cover a little bit of the basic science that underpins the idea of using cannabis in a medical setting, and where we are, what we know, and how we know what we do know. So I'll just begin. These are the declarations I like to put up. I don't have any ties to any private interests, financial relationships, and I will discuss FDA unapproved uses of drugs. So just some kind of basic questions I tend to get from my physician colleagues. What's the difference between this and Marinol? And what's the appropriate, what evidence do we have that's the strongest? Why does this even do what it's supposed to be doing? How does it work for so many different things if it really does? And who shouldn't be using this drug? So if you were to start a research project, you would go on a health question nowadays. You go to the National Library of Medicine, PubMed, and you do your search. Okay, what's articles out there? If you did a search like that for cannabis and cannabinoids, and you did it every year since 1960, this is how many hits you would get. It's a very impressive graph, and I'm going to just talk a little bit about why we're at a place now where we're getting 1,800 publications a year, 1,600 publications a year in the peer-reviewed medical literature on these topics. And this is a lot more than other topics. If you were to look up, I haven't done any comparisons, but I encourage you to check it out. So what you see in this graph is actually a couple of the points in the history of the scientific understanding, peaks of understanding. I don't know if I have a pointer, but you can see in the 1960s, 62, 64 was when THC was first isolated as a chemical component by Raphael Mechoulam and his collaborators in Israel. There was a big spike in research after that as people were trying to understand these cannabinoids. And throughout the early 70s, during the time that the federal government was actually putting a national commission to study marijuana, there was a lot of people who got research money and were doing research and publishing. But then as the tide turned, the pendulum swung, Nixon drug war began, and the war on science, as we heard, happened. There was a decrescendo in the amount of research that was happening all through the 80s, through the dark ages of the Reagan administration, where just say no. Marijuana he said in his famous campaign speech, is one of the most dangerous drugs in America, and we haven't begun to understand all the negative effects, but they are permanent effects. That's a very famous quote from the, 8-year president of the leader of the free world. So at that time, such a dangerous thing will not be researched very much, and that you can see there was quite a dip even before some of the levels that were going on in the 60s. And then, in the late 1980s, early 1990s was the big breakthrough of discovery of the endogenous inside your body cannabinoid receptors, and then their corresponding ligands or internally occurring cannabinoids, which I'll show you about. But this is what the explosion has come from in large part, and you can see now how frequent this is going on to. So another way to look at the research numbers is one article had been published in 2009, says there's 15,000 articles on the chemistry and pharmacology, 2,000 articles on endocannabinoids. This was kind of looking at the basic science. If you want to look at the clinical studies, an article in 2012 said that there was 110 controlled clinical trials in human subjects using with over 6,100 patients that have been published that have been used either cannabis or components in cannabis in human research studies with a wide range of conditions. So this gives you an idea. A lot of times you'll hear things like, well, there's really no good research, or we don't really know anything. I mean, 6,100 patients is quite a lot more than most drugs that are approved by the Food and Drug Administration today as far as the number of subjects studied. So the U.S. situation, it's true the Mississippi supply has been hard to get at, but despite all the hurdles, we have been able to put about 36 controlled clinical trials with the herbal cannabis from the federal farm. About a third of those were randomized, double-blind, placebo-controlled trials. And I'll be showing you some of those results. There is, interestingly, a long-term study that the federal government has sort of quietly done since the 1970s, where they have been giving cannabis to a series now 4 patients who have been sort of grandfathered into a program where their physicians were able to petition for compassionate use, and they were a judge said that the government has to supply them because it can help them with glaucoma and other painful conditions, but the FDA has never collected any official data on those subjects, but other private groups have. Another wave of research happened in the 1980s, and New York was part of that wave when cancer patients with chemotherapy-induced nausea and vomiting started discovering that cannabis could potentially help with the severe appetite loss and severe emesis. And in those days, we didn't have the anti-emetic drugs we have today. So 7 states participated through their health departments to provide cannabis from the federal farm to various subjects, and also some of the subjects got THC pills. In total, there was about 748 patients who received inhaled cannabis. In New York, which the data was finally published in 1990, a number of hospitals, including Long Island Jewish and all hospitals in Albany, participated in this program and administered cannabis to patients in New York hospitals. And as you can see, there was this was not blinded studies, but it was, these patients subjectively reported 70 to 100% relief from nausea and vomiting with inhaled cannabis and 76 to 88% relief with the pills. This is if you pool it all together. Just kind of to show you where we are at with this type of research. Researchers put these plots up, which kind of is a summary, a meta-analysis, a systematic review of all trials over a certain period. This was put up some Brazilian researchers. So overall, if you add up all trials on meta-analysis of cannabinoid medicines for nausea and vomiting, overall it favors treatment versus controls. So that's kind of 13 of those trials were using inhaled cannabis, and the other ones were using different forms of cannabinoids. So it's statistically significant. This is called level 4 evidence, the highest level of evidence. So contemporary American herbal cannabinoid botanical medicine clinical research sort of kickstarted in May 1998. Guess what caused that to occur? California's voter initiative, more than likely, in 1996, and that was when the first patient was enrolled in an FDA-approved study of herbal cannabis in the U.S. after 15 years. And so this is what those trials in the United States with the American farm, this is from an article I had summarized in 2009, but I think this table is still mostly correct. So appetite stimulation in healthy volunteers, HIV neuropathy, and other forms of chronic nerve or neuropathic pain, both nerve pain due to some history of a disease like cancer or a trauma or diabetes or HIV, or in some cases, I'm going to give you nerve pain by shocking you or injecting you with chili pepper chemicals and then heating up your skin and give you nerve pain that way and see if that relieves your nerve pain. Spasticity and multiple sclerosis, that's a painful muscle tone. And it's very similar to painful spasms, but weight loss and wasting syndrome, some of that research was done even here in New York City at Columbia University in their inpatient trials unit with HIV/AIDS patients. Increased pressure in the eye and glaucoma. And a number of these studies were randomized, placebo-controlled. So some patients got herbal cannabis, some people got herbal cannabis with the cannabinoids extracted out. And the subjects and the researchers didn't know which they were getting, and you're able to measure a change in the eye pressure with a little meter. And all these indications, asthma, and then of course vomiting, nearly all showed benefit for inhaled cannabis compared to the standard treatments or the placebo. This is all in the published literature. This is an example of what kind of, if you were to look in the modern FDA pharmacopoeia, what do we have for cannabinoid drugs? Since 1985, we've had these THC pills. We've had chemicals that's similar to THC pills called Sezamat or Nabilone. We have this cannabis extraction, which has been produced by a company in England, and it's basically liquid CO2. That's like a liquid carbon dioxide, liquid dry ice extraction of herbal cannabis. And they've actually been approved in 22 or 23 countries for the use in this cancer pain and multiple sclerosis pain. This is a picture of their label in Canada. and it's essentially a total herbal cannabis extract, similar to how people have been using cannabis in extract form when they take it orally, like pot brownies, or in India they drink bhang lassis, so which is kind of oral form of cannabis essentially. But this has been fine-tuned, and this has also been studied in New York City in hospitals up and down on First Avenue. Cannabis sativa cigarettes are the ones that are produced by the farm in Mississippi, and they actually have a label as well. They're rolled at the Research Triangle Institute in North Carolina, and then sent to various pharmacies. And I mentioned that there's some, since 1976, this has been available. There's also another cannabis extraction that's been studied in Europe called Canador, which is an alcohol extract of cannabis, a tincture form. So all of these things have been used in clinical studies, and not to mention in controlled clinical studies in hospitals. And then these medical marijuana phenomena in the various 18 states, the herbal cannabis there, they don't allow you to bring that into hospitals and study it in a controlled fashion. But people have published observational research to study the populations who are using this in the local settings. So I'm going to talk a little bit about some of this, the pharmacokinetics. How is herbal cannabinoid drug? What do you think about it in terms of what the body does to it? So first of all, you have to recognize that these cannabinoids, there's 6 dozen of them in cannabis, but the 2 most famous ones are CBD and THC, and they're kind of mirror images of each other, not structurally, but in terms of what they do. THC is can cause anxiety, can cause psychosis in some patients, but CBD is antipsychotic and anti-anxiety. THC in some patients can elevate seizure threshold. In some cases, it lowers it. CBD definitely lowers seizure threshold. They're very interesting kind of yin and yang. And in terms, actually structurally, they're just they're called isomers of each other. But those are the 2 most important ones. But they come in the acid form, and you have to heat those cannabinoids to decarboxylate them. So it takes a few seconds with a flame at 600 degrees Celsius. So you can take herbal cannabis through lungs, vaporization or inhalation of smoke. That's like an IV bolus in the hospital. You got your bolus of morphine. It comes on within a few seconds to minutes, lasts for about half hour, comes down in about 2 to 3 hours. That's essentially what's going on in the lung system. You can't use cannabis in an IV form because it's not water soluble. Although people have done some lipid soluble water tricks, but that's, by and large, that's the fact. That's the way it's been for eons. The gut takes in is the oral route, so that's lipophilic, alcoholic, or fluidic extracts. That's the liquid CO2. In the oral route, you have a more variable absorption, but the effect can come on between 30 minutes to 2 hours, depending on stomach contents, and last for 5 to 8 hours. There's also topical application of cannabis and cannabinoids, less studied area, but very fascinating. This is the clearance of cannabinoids through the bloodstream, hydroxylation through the liver. That's first pass metabolism when you take it by mouth, so it's a stronger metabolite. It distributes in breast milk, class C, and excretion days to weeks. So the other interesting thing in the science is not just that we've understood a lot about the human physiology, we've also understood a lot about the cannabis plant in terms of its genome, in terms of its electron microscopic structure. It's a very extremely well-studied plant. Those 16,000 articles on chemistry of the plant. So I'm just showing you kind of a picture montage of that here. If you have herbal cannabis, you can take a microscope and look at those small trichomes there where active cannabinoids are contained, those little white things with heads on them, and then you can take a scanning electron microscope and look at them up close. And then down below I have some old drawings from botany books which show in the heads of those trichomes what parts are secreting cannabinoids. And that's essentially that's the business end of medicinal cannabis. That's what you got to take in some form or fashion to achieve the medicinal effects. The genome of cannabis was sequenced in 2011, so this is a lot of interesting work going on. So now we're going to shift into the pharmacodynamics, how the body interacts with cannabinoids, or actually how cannabinoids interact with the body in terms of what receptors they're binding to. And this endocannabinoid signaling system is a fascinating area, and anybody trained in health really should understand this important system as much as you understand the dopamine system, the endorphin system, really the glucose metabolism system. It's that fundamental to physiology. So I say what's behind the runner's high, osteopathic treatment, and electroacupuncture is the endocannabinoid system. So these are some pictures I stole from some pharmaceutical company that was developing a cannabinoid drug for weight loss. But they wanted to show that cannabinoid receptors are located throughout all these different tissues: brain, adipose, muscle, liver, GI, pancreas, CB1, and this other group of receptors called CB2 in the immune system, including in skin cells, keratinocytes. So this is I don't know how much, I won't go into too much of the sort of the molecular detail, but there's a certain class of receptors called G protein receptors. These are located on the membrane of cells, and they're a way that when things bind to them, they send a signal into the cell. This is kind of a picture of those receptors look like. They kind of snake through the membrane. I'll show another picture in a moment. And you can see that these two molecules are some of those endocannabinoids that were discovered in the 1990s. Very important compounds that really are some of the most active neurotransmitters in the brain, full stop, especially anandamide. These are lipid bilayer-derived compounds that are located throughout the CNS, throughout the gut has its own nervous system. It's located in those tissues and other cells too. And I'll show you some pictures in a moment. So this is the we haven't done an actual crystal structure of the CB1 receptor, but this is what it looks like. And the details over here are the kind of physiology, which you can look at more later if you're interested. So the important thing to know about cannabinoid signaling in the brain and nervous system is that it's retrograde, which is a very unique and previously undiscovered central way of signaling. There's a few receptors and neurotransmitters that were doing presynaptic signaling, but this is the only system that we know that this is what it does, period. So that is to say, on the left side, you have a picture of a neuromuscular junction of acetylcholine. That's what Botox is targeting at when you get Botox injections. And you get acetylcholine crossing the synaptic cleft and then being chewed up in the cleft, and you get a signal sent from the neuron A to neuron B, presynaptic to postsynaptic. The endocannabinoids are retrograde signalers. They go from postsynaptic to presynaptic. They just have to do things different, right? And in doing that, they actually play an essential role in physiology called feedback, right? So if a neuron is getting too much signaling from the neuron ahead of it, too much glutamate, excitotoxicity, we can call that sometimes, the other neuron sends a cannabinoid back on demand, binds to the other receptor on the presynaptic cell, and then that cell releases less glutamate. That's the kind of physiology that neuroscientists have worked out. And really, this is kind of a Nobel Prize-worthy discovery, but I think because of the politics, it's not happened yet. But this is a huge amount of discoveries are happening here. This has been published in Nature and Proceedings of the National Academy of Sciences. I mean, it's some high-level stuff. So if you want to look at what pictures of cannabinoids look like in monkey brains, I'm sorry to say this rhesus monkey was injected with a cannabinoid binder with a radioactive label to it, and then it was sacrificed, and the brain was sliced and then looked at through a radioactive camera, and you can see throughout, as we're making slices from the frontal lobe all the way back to the cerebellum, all the areas that are in red are extremely densely populated areas of cannabinoid receptors. You can see them in the cortex, you can see them in the basal ganglia, you can see them in the cerebellum, all the way through. And in the human being, this human being was not sacrificed. This was a study done at the NIH, and they used a radio tracer and then put him in an fMRI machine. And you get a similar, you can see again with the red is the most dense, and the other colors are less dense but still present cannabinoid receptors. And then these curves here show you that these are actually cannabinoid binding and not other things. And these scientists said that the cannabinoid receptor is one of the most abundant receptors in the central nervous system, rivaling the benzodiazepine, striatal dopamine, and glutamate receptors, and it's 10-fold more higher prevalence than opioid receptors. So this really should be really, again, because of the politics, even though we've known about this for 10, 20 years, is not being taught in medical schools in any systematic way. So physiological effects of endocannabinoids, there's so much research, but as you can imagine, this homeostatic system is involved in a large number of processes since it's widely distributed, and this has sort of been shown in feeding behavior, energy metabolism, pain perception, motor function, posture control, learning and memory, emotions, immune and inflammatory responses, cardiovascular function, even bone growth in different aspects of the reproductive cycle. These are just an sampling of some of the research that's been published in the literature in various animal models and in human studies that have shown the essential function of this cannabinoid system. Just to give you an example, if failure to thrive is important, an infant is born, or in this case they studied in rat pups, you just don't take enough milk. It turns out that if you block cannabinoid receptors and then pups are born like that, they will have failure to thrive. So cannabinoids are essential to life, essentially, and that's why cannabinoids are found in the breast milk of nursing mothers. So now I'm going to focus on pain because there's so many different areas we could talk about. But interestingly to note, if any of you, because some of you are in the mental health field, certainly pain, physical pain, emotional pain, there is pain circuits in the brain and nervous system. All these areas of the brain and nervous system that pain circuits have been established in, cannabinoid receptors are there. So that's a couple of the areas. And interestingly enough, the periaqueductal gray is a very important area to know because that's called the descending pain pathway. That's one of the areas where your brain kind of tamps down the pain that's going on somewhere else. So famously, if you are stubbing your toe, but you're being chased by a saber-toothed tiger, you don't have time to feel your toe's pain. And also how to adapt to a painful stimulus over time. It's because of this descending pain system. And patients who have chronic pain syndromes, they have problems in the descending pain systems. And interestingly enough, cannabinoid receptors are densely located in those areas. And then, the whole nausea and vomiting business, now we know why cancer patients have relief from nausea and vomiting when they inhale cannabis, because there's cannabinoid receptors in the brainstem located in what's called the emesis circuit, the part of the brain that was evolved to vomit when you had a toxin and a poison. You just got to all of a sudden throw up. And this is probably where the area in the brain called the nucleus solitarius, where those are working. That's been shown through animal studies in shrews. This is the neuropathic pain stuff. I'm going to skip through some of this because it gets a little too detailed. MS is an important fact in cannabis, that patients with MS receive relief. In animal models, we've seen that left and right. So I show you that, but in a minute I'll show you the human studies. Adverse effects of cannabinoids in cannabis, I'm going to just turn to briefly. Important thing to note that you don't have lethal overdose with cannabis or cannabinoid drugs. There's no end organ damage particularly, or labs to follow. Like, for example, you get put on ibuprofen for a long time. Your doctor should check your liver function tests, or your kidney function tests, If you're taking lots of Tylenol, you should be checking your liver function tests. But we don't. There's nothing like that to follow necessarily with use of cannabis. Institute of Medicine said the dangers of cannabis are within the range of other adverse effects with other drugs that we use. I'm going to let Julie focus on some of the other things. Thank you, and related to the risk factors for dependence and abuse, and the withdrawal syndrome, which is this mild and short-lived, according to the Institute of Medicine report. So. This is Marinol capsules, which have, again, been approved since 1985, and this is the overdose symptoms and signs on the package insert. So that's what the FDA says is acceptable, but that gives you an example of concentrated THC overdose, what it looks like in terms of FDA labeling. I want to state that emphatically that there is no evidence-based studies that have linked cannabis use with exacerbation of schizophrenia in terms of a dose dependence, in terms of a cause and effect relationship, but we'll go more into that later on today. And in terms of smoking risks, we can't find links to COPD or lung cancer. In fact, protective effects have been described. Let me see here. So I'll end. I'm running out of time here, but you should know these are examples of some of how these clinical trials are done in the United States. You can see that there's a pharmacist here who's dispensing cannabis. This is a patient in a San Francisco General Hospital unit, and they use a pain scale to tell their before and after pain levels, whether they're using active or placebo. And this shows you as the patient enters the study. This is a summary of all the subjects. This is a pilot study in in 2007, neurology, pain scores drop. As they stop and leave the study, pain scores return back to the baseline. And the placebo patients, they had a drop too, but the active drug beat the placebo. So yet again, and this was a neuropathic pain in HIV patients. This is graphs of spasticity in multiple sclerosis patients, and just shows you before treatment and after treatment. For the placebo patients, the Ashworth pain spasticity scores didn't really change all that much, but before treatment and after treatment for the patients using cannabis, the spasticity scores improved. And there's also these very large studies that have been done with cannabis in oral form. And for example, one study involved 33 clinical centers and 666 multiple sclerosis patients in the US and the UK. And in these huge studies with 600 patients, there's significant improvements that have been noted in spasticity and pain and sleep quality. And this is the cannabis that's in the liquid form that you can swallow. And again, the adverse effects were minor and well tolerated. And interestingly enough, in the follow-up study, they showed improvements in the mobility index, and they also showed that the patients who got cannabis went to the hospital less often in relapses for MS. So that's, I think I'm going to run out of time here. The last thing, give me one more moment, I want to show you about mental health. So interestingly enough, the 1937 story of cannabis the AMA did say that cannabis had uses in the field of mental health. And the Dr. Woodward, who testified from the AMA, said that there are uses of cannabis that nobody can no other drug can substitute for. And this is, I'm quoting here from the congressional record. And he says that cannabis can be used to revive old memories, and psychoanalysis depends on the revivification of hidden memories. And he stated, the doctors in the AMA stated in 37 that was a use of cannabis. This was a paper in JAMA published on that topic. And you can see here that they mentioned that therapeutic uses to reveal the subconscious mind content. And there was a doctor named Herman in 1969 who was a psychiatrist who used marijuana, cannabis, in psychotherapy. And he actually was here in New York in the kind of psychotherapy scene, and then eventually moved to Texas. And this is before 1970. He had a license from the federal government to prescribe cannabis, the only psychiatrist licensed to use cannabis in psychiatric work with the patients. And his main interest was to use an adjuvant in psychotherapy. And I'll leave this up here, some of his findings. Thank you very much.
Thank you, Sunil. Fascinating. I'm going to ask again that you all hold your questions, and I want to introduce Dr. Julie Holland.
Good evening. I'll be brief. I like the Q&A the best, so I'm not going to say too much. I'm a psychiatrist. I have a practice where I sit in an office and prescribe things to people all day. And in Manhattan, that is an easy job. 1 out of 5 Americans right now is taking some sort of psychiatric medicine, and in women in America, it's 1 out of 4. So, I think that's kind of crazy. I used to run the psychiatric emergency room at Bellevue Hospital. I ran the psych ER every Saturday night and Sunday night for 9 years. And when I was there, there's a drawer that keeps opening here. What I saw firsthand night after night were the ravages of alcohol, absolutely. And secondarily was the ravages of cocaine and crack. And never, basically, in 9 years did I have to deal with somebody who was a chronic cannabis smoker or who was addicted to pot who had some sort of a problem. I mean, I personally never, ever encountered a patient like this. I know that they exist, but statistically, they are few and far between. What if I need water? This is from my well where I live. It's much better than Poland Spring. Anyway, so Sunil, you covered a lot of ground, and I totally appreciate it. One thing that I was shaking my head no is not that your number was incorrect. I just wanted to explain. You said that 11% of ER visits are about marijuana, and the way that the data gathering works is, when somebody comes in because they broke their arm, if they say that they have ever smoked pot, that goes down there. Or if their urine comes up positive for THC, which it can for up to a month if you're a chronic smoker, and at least a week or two if you're not. So anybody who comes through an ER who admits that they smoke pot or who comes up positive on the Eutoxis, which is a lot of people. So it makes it seem like, people are coming into, like 11% of people in the ER are coming in because they had some problem with cannabis, but that data is very misleading. I don't mean to minimize the problems with cannabis. One of the things that's happening now with things like spice and K2 and these synthetic cannabinoids, these white powders, is it's really strong and it's very disorienting, and people are more likely to have panic reactions or to really feel, sort of separated from their body or delusional or paranoid. So when you take something that is pure THC, for instance, like prescription Marinol, it's very, it can be very psychedelic, it can be very disorienting. When you have the plant, you don't just have THC. You've got something that tamps down THC, which is CBD, cannabidiol, and I'm glad that Sunil spent time teaching you about cannabidiol. It's really important. If there was a way that we could just have pure CBD, and there is experimentally, but we don't have the option for prescribing, but that would be lovely. It looks like CBD can make you less likely to have seizures, that it can help to balance your metabolism, that it can decrease anxiety, that it can decrease psychotic symptoms in patients with schizophrenia. And this is experimental studies that have been performed. So when you have the whole plant, you don't just have pure THC like you do in these powders. There's something called an entourage effect, where all the chemicals in the plant work together to create an experience. So this is why I'm pushing for medicinal cannabis, because in many ways it's better than prescription Marinol. And by the way, how crazy is it that I can prescribe, any doctor can prescribe Marinol to their patients for any reason? It's a Schedule III drug. It's lower than Percocet. It's less regulated than Percocet. And it gets you really altered and for an extended period of time. And it really doesn't work. When you do head-to-head comparisons of THC pills and the whole plant, it really doesn't work as well. Anytime that you ingest cannabinoids orally, it takes longer to come on, and your liver creates a metabolite. Your liver does something to THC. It creates 11-hydroxy-THC. And 11-hydroxy-THC is even more psychedelic than THC is. It's even more disorienting. And so when you eat, if you have pop brownies, for instance, if anyone here is the difference between smoking, a couple puffs off a joint and eating a pop brownie, you can attest to this. It takes longer to come on, lasts a lot longer, and you're a lot higher. So it's the same thing with prescription, with this Marinol pill, is you're much more altered for a longer period of time. What's nice about a patient being able to smoke the plant, besides having the CBD and not just THC, is they can titrate their dose. They can take a little bit and see if it's helping their symptoms, and if it's not, they can take a little more. With the pill, you can't unswallow the pill. You wait, 30 to 120 minutes, and once it kicks in, you're off and running for 5 to 8 hours, sometimes longer. I am embarrassed to say that my... No, never mind. I'm not going to tell you this story. Okay. No, because I'll start to cry. That's why I'm not going to tell you. Let me just say that, and in the elderly population, it's very easy to overdose on edibles. Let's just leave it at that. Anyway, I am a psychiatrist, so I want to talk about psychiatric disorders that can either benefit from cannabis or cannabinoids or can be exacerbated by them. So I'm very interested in schizophrenia. 1 out of every 100 people worldwide has this disorder. It's a horrendous disease that comes just in your late teens, early 20s, when you think everything's okay and you've joined the army or you've gone off to college and things disintegrate and you start getting paranoid and disorganized and hearing voices. And then you're stuck with that for 50 years. It doesn't kill you. You're just crazy and miserable for decades and decades. And the medicines to treat schizophrenia are not that great. And the side effects are pretty horrible. But it turns out that CBD can really help a lot of the symptoms of schizophrenia, including some of the cognitive disorganization that the medicines really don't touch. On the other hand, THC can make a lot of the symptoms of schizophrenia worse. So Sunil alluded to this issue. Pot does not cause schizophrenia. period. Schizophrenia is a genetic predisposition, and, in my opinion, you're either going to get it or you're not. You can't, give yourself schizophrenia. But there are a bunch of studies that are looking pretty convincing that if you smoke a lot of pot when you're a teenager, and you've got a tendency towards psychosis, or you've got relatives who are psychotic or relatives who are schizophrenic, you can bring this disease on earlier than you would have gotten it and worse than you would have gotten it. So one thing that Andrew asked me to talk about was screening patients, who's appropriate for medicinal cannabis and who's not. And so one thing I would say is, unless your kid has cancer or intractable epilepsy, I'm not comfortable recommending medicinal cannabis for teenagers because there is this issue. When they look at pot-smoking teens who are very heavily sort of addicted to pot, they don't do very well over time. If you start smoking in your late teens or your 20s, it seems like it's less debilitating. So there's something, when you're a baby and you're growing, your brain, you come out with a slightly big head. But it just gets bigger and bigger, and your brain makes all these connections, and there's so much growth going on. But then in your teenage years and late teens, early 20s, there's something called pruning. In the same way that a bush grows out and then you start to prune it back, your brain does the same thing. And when you're pruning, it seems like it's a particularly vulnerable, delicate time in brain formation. And that's when the pruning happens, is when schizophrenia happens. It's when first break psychosis happens. Sometimes people become bipolar. They have their first manic episode. And it's also, unfortunately, a time, when teenagers experiment with drugs quite a bit. So it's really bad timing. If there's any way you can tell your kid, look, I know, you want to try all these things, but the longer you wait, the safer it's going to be. So I'm not necessarily, and the New York State law certainly is 21 and over. I mean, they're not recommending medicinal cannabis for children or teenagers. Although there are some really interesting case reports of kids with horrible intractable tumors who are basically being cured with very high dose CBD or other cannabinoids. There's no age restriction in the bill, I'm hearing. I really thought it was 21. All right, there's a little bit of dissent in the room about whether or not there's an age restriction, but I'm just going to move on. So anyway, that's schizophrenia. By the way, if anyone here is a psychiatrist or a research scientist and you want a lot of information and a lot of references, just email me and I will send you a 20-page document. I opted not to use slides and give you references, but I have all kinds of things in my computer I'm happy to send you. So then there's post-traumatic stress disorder. I'm the medical monitor of a research project, which is FDA approved, but completely stalled because our government will not give us any cannabis, treating veterans of post-traumatic stress disorder. So when you have PTSD for any reason, you're just kind of on DEFCON 5. You're on high alert. You're very anxious and wound up. It's hard to go to sleep. It's hard to calm down. You have an increased startle response. You're hypervigilant, looking over your shoulder. And you're flooded with memories of this trauma that happened. And what animal studies of PTSD models have shown, and what some clinical trials have shown, is that CBD in particular, but cannabis in general, can just sort of calm down the hypothalamic pituitary axis, is an axis that keeps you sort of keyed up. That it can help to extinguish fearful memories, which is really important. That it can help to induce sleep. That it can help to just calm down the anxiety and the hypervigilance. So again, it looks to me like a high CBD strain is going to be more effective in treating post-traumatic stress disorder than a high THC strain. So we asked the government to please give us a couple different strains so we should see for ourselves. But one fascinating thing about our government is that if I want to do a research study and give somebody heroin, and the FDA says this is a good research design, this protocol makes sense, you go give them heroin, cocaine, whatever, any Schedule I drug you want. If you want to give somebody cannabis, you have to go ask these guys also. So you have to go to NIDA, which is the National Institute on Drug Abuse. So National Institute on Drug Abuse, NIDA, they fund most of the drug research, not just in America, but around the world. But they have a very specific agenda, which is to look at the harms that drug use causes. They do not have a research agenda to look at the benefits that any drugs can cause. So FDA says yes, study looks good. NIDA says, we're not comfortable with this, we don't think so. And then you can't get your pot and you can't do the study and you're stuck. So this is called the NIDA monopoly. If anybody wants to learn more, just Google NIDA monopoly and you will see one of the lovely things that our country does. I mean, this whole idea that cannabis is Schedule I is just ridiculous. This is an ancient medicinal plant. It has been around for thousands and thousands of years. Just because some weird things went down in 1937 doesn't all of a sudden strip it of its medicinal properties. And saying that it is Schedule I and that it has no medicinal use, is a little like saying the sky's not blue. I mean, it's just silly. And, our own government has a medical use patent saying that cannabinoids are neuroprotective and can help protect the damage that's caused by a stroke. So, it's not a medicine, but we're going to take out a medical use patent. I mean, it's crazy. Or, it's not a medicine, but THC pills, which are so much stronger, that's Schedule III. So there's a lot of sort of illogical things going on in our drug policy. Anyway, I got a little off with PTSD, but it's just because of this study that's making me kind of crazy. All right, I'm off my soapbox. So, as an antidepressant, cannabis has a very long history of being used. For many people, it is sort of an immediate acting, euphoriant experience. And other people get anxious from it. So, and that really has a lot to do, there's Indica and there's Sativa. When I started by the way, I'm editor of the pop book. I did not write the pop book. It's like this thick. I wrote a little bit of it, and I got a lot of other people to write it. When I started researching the pop book, I did not know the difference between Indica and Sativa, and I was made to feel a lot of shame about it. So I don't want you to feel that. So in case you didn't know, because I didn't, there's two sort of basic different kinds of pot. And Indica tends to make people more sleepy and more sort of, I don't feel like getting off the couch right now, and less anxious and just kind of, mellowed out. And I guess sort of the classic, Hollywood picture of the stoner. And Sativa is a little bit more, it offers a little bit more clarity, and people get sort of creative and they have a lot of ideas, a little bit more uplifting. It's not so sedating, and there's no sort of couch lock. And in the same way that when two people have a child, that child's got its own genetics, and the parents have its own genetics. It's the same way with cannabis. Every time two plants mate, there's a genetic assortment, and the baby plant has a whole new set of genetics. So every time you buy your little plastic container from your dealer, you're getting something different, and you're getting a plant with different genetics. Now, there are clones, obviously, so if you know what you like and you can get that, and that's what's great about a dispensary, is if you want a high CBD strain, like let's say you want an indica because you need help sleeping, or you want a sativa because you have attention deficit disorder, you want something that'll help focus you, or you want a high CBD strain because you don't want to be very altered and you get anxious from pot. If you have a dispensary, you can go and tell them exactly what you want, and they'll say, oh yeah, that one's over here. And when you go back next month, that one's over here, same one, same clone. In New York, we don't have that. In New York, my joke is like, it's a mixed bag. You get what you get. And, you may get the same thing next month from your dealer, or they may not have that and they get something else. Or they put, oh yeah, you like that? They'll put the label on, yeah, this is a Kush, So you don't know what you're getting. The other thing that kind of drives me crazy is I have patients who would really benefit from medicinal cannabis. And they don't know where to get it. They don't know how to get it. They don't want to break the law. They want to know that they're going to get, sativa or a high CBD strain, and there's no knowing in New York. And, some of them really don't know where to get pot. And I have to say, well, do you know any kids? And that's pitiful, but the truth is it's easier for kids to get pot than it is for them to get alcohol, because they get carded. When you try to buy cigarettes or alcohol, you get carded. When you try to buy pot, nobody cards you. And for most kids in New York, it's easier to get pot or, to buy prescription drugs on the street. So that's crazy, and my hope and my assumption is that if we have some sort of system where things are more tightly regulated, I don't know whether it'll be any harder for kids to get pot, but I know that it'll be easier for my patients to get the medicine that I think would help them. So I think that would be lovely. Attention deficit disorder, I mentioned. So there is sort of, there's a lot of conflicting, when you start looking at the clinical research using cannabinoids and psychiatric diagnoses, it's a lot of conflicting data. And I think part of that is because they're not separating out THC and CBD. And I think that if you do that, it will be much less conflicting. When you're using the whole plan and when you're using different strains and you don't necessarily know what people are getting, the data is muddy. So it looks like, for instance, if somebody has attention deficit disorder, you're better off with a sativa, which is sort of more clarifying and focusing. But there are tons of case reports of people with ADHD who swear by cannabis and say it's better for them than stimulants. I could spend some time telling you, I prescribe a lot of stimulants. I mean, I've got, the Wall Street guys who are sitting in front of a computer for 16 hours at a time, which is somewhat unnatural, but when they take Adderall, they can do it. And these guys have been on stimulants, since they were 8, 9, 10 years old, which I don't know if that's really a good thing or not. What I do know about cannabis is that it is non-toxic to your body. It is not toxic to your brain cells. It is not toxic to your liver cells. It's safer than many of the medicines that I prescribe in my office. And not only is it less addictive than cigarettes and heroin and cocaine and alcohol, but it turns out now that if you create just the right blend of fat and sugar and salt, rats will self-administer that over cocaine. So I'm going to say that cannabis is less addictive than Doritos. So that's something. I'm just looking through my little Rolodex to see if there's anything else. My notes in my head. I'm going to save it all for a Q&A, and because I know Sunil went a little long, so I'm going to go a little short. Thanks.
Thank you, Dr. Holland, for that clarification. I've been working with the NFL Substances of Abuse program for the last 14, 15 years, and one of the problems that the NFL has is that players use marijuana for attention deficit and for pain. And if you've ever had to study a playbook and you have ADD, it's pretty difficult. But you smoke some marijuana and it becomes, a little bit easier to do. But the problem is you also end up in violation of the substances of abuse policy and fined and banned and all of that. So our last presenter is Dr. Andrew Tatarsky, and I'm going to keep him on a strict time limit so that we can have some time for Q&A.
So I'm going to be speaking as a clinician. I've been working in the field as a psychologist, specializing in working with people with substance use problems for 30 years. I would say that although Julie Holland says marijuana is about as addicting as Doritos, probably those 9%, although, percentage-wise, it's a smaller percentage maybe that gets into trouble with marijuana than with any other drug. We see those 9% in our practices. So from the clinician's point of view, marijuana can be extremely problematic. I'm also here as the director of the Center for Optimal Living. We offer comprehensive therapy services for the full spectrum of people with substance use and other risky and addictive behavior. And we work from a harm reduction point of view, meaning that we see people in treatment across the whole spectrum. We see people pursuing abstinence and who are abstinent, but we also see a lot of people who are not committed to abstinence or clear about what they need, and we're treating them. And a lot of those folks are people who come in self-referred for problems with marijuana. So, and we have a significant percentage of our patients that are grappling with marijuana. But I'm also here as the president-elect and a representative of the Addiction Division of New York State Psychological Association, which, both the Addiction Division leadership and the New York State Psychological Association have both signed on with support for the medical marijuana bill. So, and that really reflects my perspective that though I'm actually dealing with people that are having significant issues with marijuana, I also think, and I think I've been more convinced tonight with these powerful presentations that there is evidence that marijuana is an effective medicine for some people. And the issue that comes up for me as a clinician is both with the folks that come in, using illicit substances and medical marijuana patients, and I might also add the large group of patients that are using prescribed psychoactive medications. There's always a risk-benefit profile. And our challenge as clinicians is to help people negotiate, empower people, and support people in a variety of ways to negotiate for themselves that risk-benefit profile. And that is to get clearer about in what ways substances may be helpful, either for their prescribed effects or for their recreational uses and benefits, and in what ways are they problematic. And that's what we deal with as substance use treatment professionals with all of our patients, to try to help people, empower people to make healthier and better and wiser choices around their relationships to substances, such that some people determine that no substance is the best choice and choose abstinence, and others find some more moderate, controlled, healthy relationship, whatever that might be. So I think we have a lot of knowledge as treatment professionals that I think needs to be in the medical marijuana community. And I think it actually needs to be more fully integrated into the medical community, because I was recently on a panel dealing with the prescription opiate epidemic in this country. And the problem of prescription opiate abuse, which is the major leading cause of death in this country from substances, or I think, it's beating out car accidents. Yeah, beating out car accidents. The leading cause is the overprescribing by physicians. So it seems to me that we as treatment professionals have to be thinking about how, if and when, and it looks likely that some version of a medical marijuana bill is going to go through, how we as professionals can positively impact on the prescribing of medical marijuana and have some influence in, and I think that it's possible that our wisdom, our collective wisdom, can inform protocols around medical marijuana that could actually set a standard, that is not being done very well in a lot of other states, and is not being done around the prescribing of more dangerous substances like opiates. So I think we have a real opportunity here. I just also wanted to say parenthetically, I'm a relative newcomer to medical marijuana. I've become interested over the last few years in it because it looks like it's happening, and I think that we need to have something to say about medical marijuana as substance use professionals and mental health professionals, and also to think through, and this is really the sort of the theme of the day of the forum, is how is this going to impact on us as clinicians in our practices, in our treatment centers? So I think there are these two issues. What should we be saying, or what kind of impact should we be having on the medical marijuana community or movement, and how is this going to impact on us? So I thought I would just raise some questions that occurred to me and share with you some of my own ideas about this as a way to set the stage for a discussion. These are some of the things that I thought are important for us to consider. Who are medical marijuana patients, or who are the people that will be seeking out medical marijuana? And I think, one of the big claims against medical marijuana is that like in places like California and elsewhere, that it's really just a smokescreen for legalization, and everybody's just, pretending that they have issues and so on in order to get legal marijuana so they can get high. But, this gets into the whole question of why do people use substances, and why would people go to such great lengths to go to a doctor and to pay money and become a public patient to get high? Let's think about that as an interesting and complex question. Will medical marijuana encourage illicit use and addiction, increase rates of addiction and illicit use? I think somebody said before, we have to be very clear that we're not talking about legalization. We're not talking about, changing the regulation for legal marijuana. This is a highly restrictive medical marijuana bill, but that's, I think, an important question for us to think about together. Might there be a beneficial impact on the use of marijuana overall for all of our patients, for the patients that come for marijuana problems? And for those patients in psychotherapy that are using marijuana. And I imagine those of you that are not addiction specialists, if you think about it and you begin asking your patients about it, a significant percentage of your caseloads are using marijuana. So might there be a beneficial impact? And what should mental health and substance use providers know? And what should medical marijuana providers know to address the potential risks? And I might just ask you to think about what other questions might have occurred to you as you've been listening to these brilliant presenters before me. So I think that this is a broad, diverse group of people that are likely to seek out medical marijuana, certainly people with severe medical illness. I think it is likely that people that are severely dependent on marijuana for a variety of other emotional and psychiatric issues, trauma, and so on, are likely to be seeking out medical marijuana. And that's going to be an interesting challenge for providers, because I think that a lot of those reasons for using are going to be off the bill, or, so, as I was listening to the presentations, I was thinking about a patient that I saw today, and this happens in my practice all the time. A woman who is a heavy marijuana user. She's a 50-year-old woman, professional. She has a history of physical abuse as a child. So she lives with tremendous anxiety, kind of a post-traumatic, hypervigilance, and all of the kind of symptoms that go along with it, self-esteem issues and so on. And she has lower back pain, and what she reports is that the marijuana helps her with her anxiety, it helps her sleep, it helps her with her lower back pain. It basically helps her feel like she can enjoy the day in a way that she rarely feels like she can. Is she a medical marijuana patient, or is she a person addicted to marijuana? I mean, this is the question of what is addiction, what is the nature of dependence, and so on. And we argue at the Center for Optimal Living, I think progressive people are arguing that heavy use of substances and problematic use is virtually always related to complex trauma and complex other issues. So I think that this is an important group of people we have to deal with. And of course, there are going to be some people who just want to get legally high. And is it better to get marijuana from your dealer or from a doc? So this is an interesting thing, that the medical marijuana bill may actually bring lots of folks into the offices of physicians who can actually evaluate them. And possibly, if they have the adequate training and understanding and relationships to the rest of us treatment providers, make appropriate referrals. That sounds like a good thing to me. I think most of these folks who are going to be coming in are coming in with lots of shame and guilt and fears of being branded addict. Let's question what is addict. Does addict really capture the complexity of the reasons that people use marijuana for all sorts of reasons that I've just hinted at. I think that this whole movement has to really consider how it's going to deal with stigma, educating physicians and dealing with internalized stigma in these patients. Many of these people are tremendously isolated. That's not mine. No. So these folks coming in are coming in very complicated emotional states. Many of them and we hear this from our patients all the time, don't have anybody that they can talk to about their marijuana use. So this medical marijuana prescribing doctor can play a very, very important role depending on how the doc engages the question of their desire for marijuana. Will it encourage illicit use and addiction? Well, I don't think that the fact that marijuana is decriminalized or prohibited is really an effective deterrent to the use of marijuana for anyone in New York State that wants to get it. Somebody mentioned, Julie mentioned, something that a 20-year-old patient of mine said the other day. He had got wind of me going to, talk here at this. And so I figured I would interview him a little bit and ask him what he would want me to share. And he said exactly what Julie said, that marijuana is much easier to get than alcohol or tobacco for young people. He thinks, 50, 60, 70% of the kids in his high school are using marijuana or know somebody who they can get it from. So I don't see that that this is going to change access in any way. I do think that substance use clearly is influenced by social attitudes, so we need to think about just what kind of impact might it have on people's motivations to use a substance if it now becomes thought of as a medicine as opposed to just an illicit prescribed drug. Is that going to make it more desirable or less desirable? I think that misuse and addiction, as I was just suggesting, is related to all sorts of complex other cofactors, so that a positive change in the valence of a substance alone is not going to explain why certain people get into serious trouble with it. I think that there are always complicated cofactors. It may be, lifestyle, peer group, difficult emotional states, and so on. Managing trauma, as in the patient that I alluded to. I actually think that it might have a very beneficial impact and reduce the incentive, to some extent for many people who are engaged in illicit drug use. The fact that the drug is illicit is part of what gives it its charge. Many people smoke lots and lots of crack and don't even really enjoy the effects of the drug. There's something about it being kind of conferring outsider status. It's a way that you can express certain rebellious feelings or self-hating feelings, for that matter, by engaging in an illicit activity. To turn it into a medicine, which actually, we're trying to figure out what the legitimate uses are for, changes the whole valence of it. And an experience I had in two different places that sort of speaks to this is running into people who were on prescribed heroin in England and in Vancouver, two different conferences I was at. And they, first of all, were well stabilized on prescribed heroin. One of them, after going in and out of drug-free treatment and methadone and all sorts of other things, discovered heroin was the best stabilizing drug for her. And after several years of stabilizing her life, she had now decided she was ready to get off it because she was tired of taking this medicine every day. Similarly, the guy that I met in Vancouver, I asked him, so how is it going? And he said, well, it's been great for me, but, I hate having to go to the damn clinic every day and get the heroin, people who are dependent on substances don't necessarily like being dependent, and particularly if it's a medicine that you have to take as opposed to a drug. And I think I spoke to this before. I can see that, medical marijuana patients or people pursuing medical marijuana now can be assessed as a screening by the physician, who can then potentially refer if there are mental health or substance use issues going on. So I think this could be a real good thing for marijuana users and as a way to get more people into treatment. I think that we as providers need to really know about the risk-benefit profile of medical marijuana and other prescribed drugs. I think that as professionals, mental health professionals, I think that we all need expertise in substance use because, I've taken lots and lots of informal polls of psychotherapists around, what percentage of their patients are using substances, and it's generally around 40 or 50 or 60%. And a lot of them are on a spectrum of difficulties. So I think that must be part of your training, and you need to really seek out this information, not just about marijuana, but about all drugs. And what are the medical indications? What are the indicators of misuse and addiction? I think we all need to know that, even if you're not a specialist. And how to collaborate with doctors as consultants, because many of these docs haven't had the training, they don't have the sophistication. I think that we should be doing that more and more with all of our patients that are on prescribed medications, having a much more activist kind of role in talking with doctors about what we're seeing with prescribed meds. And also we need to know when to refer to a substance use treatment specialist. With medical marijuana providers, obviously the goal is to figure out a way to maximize the effectiveness and minimize risk. These people, I think, need to have some basic understanding of abuse and dependence so that they can actually work with their patients collaboratively to be assessing that. And I don't know if I don't have that much time to go into all of my slides, but and I think that we need to develop a harm reduction protocol. That is, how does the doc go about creating a relationship with the patient in which you can provide the tools to the patient, the knowledge, the understanding, and together work in a collaborative way to assess in an ongoing way how this is helping and what might be indicators of excessive use, dependence, problematic use. So that needs to be part of the prescribing practice. I'm going to run through this very quickly. I think that the alliance is the key. And, I hate to say it, but when docs are only having 5 or 10 minutes to make prescribing decisions, that's really problematic, for all drugs. And that's problematic here. If you don't have a relationship with the patient, how can you create a space to really create safety and create a space where the patient feels safe and comfortable to really talk about, what they're doing and why they're doing it and how they're feeling on it and all of that. There's all sorts of data that shows that where the alliance is strong, adherence to medication increases, whether it's HIV medication, psychiatric medication. So the alliance is all about having a particular type of caring, connected relationship. Obviously, these folks need to understand about stigma and not jumping to conclusions, working on monitoring their own reactions. I think physicians need training in countertransference and all sorts of things because they act out this stuff all over the place. And to have a way of talking with patients about the difference between use, abuse, dependence, and finding a way to kind of set the stage for that. What is my attitude about all of this that will actually help you to feel safer, to talk openly. This is more about therapeutic alliance. We go into all of this with our training of therapists and substance use people, but I think docs need to know some of this basic stuff too. how do you create safety? How do you create an empathic space where people feel safe revealing, shameful, difficult issues? Patients need to be educated about vulnerability, about the risks of misuse, and I think about the different motivations for why a person may want to use a drug. Many pain patients may be experiencing emotional pain. Patients who somaticize complex emotional issues may report physical difficulties. And if the doc doesn't have a sophisticated understanding of how to negotiate that with the patient, so that the patient can begin to make fine distinctions, you're now over-medicating when maybe there needs to be some psychotherapy or some stress management or some kind of other intervention. The collaborative assessment needs to be going on and teaching the patient skills for being able to self-assess, tracking urges, what we call urge surfing, unwrapping the urge, why do I want to use, charting, tracking, and doing a microanalysis. These are some techniques that I think docs could learn and practice. Teaching patients alternative techniques, alternative ways of managing stress, emotion, difficult feelings. This is key to pain management with opiates. If people have other ways of reducing the discomfort, 3 minutes, okay. And so, at the center, we have, an increasing number of patients exercising, doing yoga, practicing mindfulness. We have mindfulness skills groups. And patients love it because patients don't like to be out of control with their substances, whether they're self-chosen or prescribed. They want to have some tools for being able to gain a greater sense of control, choice, and have alternative ways of managing. These are some, things that docs could do to take all of that into a brief intervention, discussing risks, alternative strategies for managing excess or managing other triggers or emotional reasons for using, and to know if the concern persists, that they've got a whole bunch of specialists, like many of the people in this room, that they can refer to for further assessment. So I think that relationship to substance use specialists is key. And I guess that's all I have to say right now. Okay, thank you.
Wow, so we're just going to go maybe 10 minutes beyond. I'm going to invite all the panelists up. Gabriel? So we're about 7 minutes to 9. I want to thank all of you again. Andrew talked about evaluating someone. I evaluated this young man today. He's 25 years old. And he, just want to throw him out as sort of a beginning case. He's a New Jersey resident. Has severe gastrointestinal pain. Think that it might be some kind of Shigella dysentery or something of that nature that he actually got while he was at a wilderness program and drank some water that he shouldn't have drank. And he's on, now he's on a fentanyl patch. Prior to that, he was using hydrocodone, switched to heroin, began to use it IV, and also smokes marijuana as a way of being able to get some sleep at night. Has quite a bit of anxiety, and is experiencing auditory hallucinations. And one of the things that sort of is a hallmark of schizophrenia is this sort of running commentary about what it is that he's doing. So today in my office, he basically said that he would give up the Xanax, the fentanyl patch, He's been taken off the hydrocodone, but he'd give all of that up because the marijuana seems to be what helps him the most. So what do you guys think about a case like that? And then we'll open it up for questions.
Well, just parenthetically, the same young man that told me that he could get marijuana more easily than alcohol also went through this brilliant discussion of how marijuana is a magical drug because it actually has many of the effects that all of the other psychoactives have. You know, certain strains and at certain doses can be activating and focusing. Other strains can be anxiolytic, and other strains are help with pain, as we've heard. So, you know, my sense is that the more that we know about it, the more research we can do, the more we can actually help people use it effectively or find other ways that might be more effective.
My thought on that is if he does have a Shigella-related illness, or if he did in the past, it sounds like the story is that he got Shigella and then developed chronic problems in his gut after that, like cramping and maybe some pain, maybe diarrhea, constipation, back and forth, especially with all the opioids he was on, potentially. I wouldn't be surprised. So, you know, maybe so at first I was thinking, well, if you got Shigella, you need antibiotics. You know, you don't need like, you know, palliation. You can cure Shigella with antibiotics. But if it's developed a chronic problem from that, people do develop can develop inflammatory bowel diseases that were preceded by an infectious organism. In fact, some people have theories about Crohn's is caused by that. And we do know Crohn's disease does have, in randomized placebo-controlled trial in Israel, just published, showed that Crohn's patients did have relief compared to placebo-using Crohn's patients. It's a small study, but it was published, and they used a standard index of quality of life. And so, you know, maybe it is an appropriate treatment for that type of gastrointestinal problem. But because it's maybe mixed in with some other misuse issues, you definitely would need to dig deeper into the relationship with the substance and educate about the proper way that it would be used to help with those symptoms and refer appropriately for the other problematic issues that could be around it. But that's my thoughts.
Thank you.
I just think it's possible if you have a 25-year-old guy who's hearing auditory commentary that, you know, he's reaching for anything he can to help his psychotic symptoms, and he may need a low-dose antipsychotic in order to get off some of these other substances.
Yeah, I did mention that he was recently prescribed Prolixin. So the sort of denouement of all of this is that he has 3 doctors, and none of them have been speaking to each other, and I've been brought in to kind of say, hey, gastroenterologist, you might want to speak to the psychiatrist, you might want to speak to the pain doc. And so I think it kind of echoes what you talked about, kind of bringing people together and having them speak with each other, because that's the only way that you can work with these complex cases. But I do believe that you can have addiction and use a psychoactive substance that one may have had some affinity for in a way that is therapeutic. So that's just sort of my, if you manage it. So questions? Yes.
Hi. Thank you so much. I really appreciated everybody's presentation. I'm not on the practitioner side of it, but I am on the patient side of it. So this has been a really refreshing perspective to get. One question I have, you know, it seems to me like a lot of people use marijuana recreationally in non-harmful ways without struggling through addiction issues. And I guess I'm curious from doctors here, what you look for to distinguish between non-harmful recreational use and addiction.
Well, first of all, I think it's important to shift from sort of more traditional ideas of, you know, addictive disease, non-disease, or, you know, and I think that the world is catching up with this perspective where we're now thinking of substance use disorders, substance use issues on a spectrum of severity. So that what we're really looking at is the consequences, the quality of the relationship, and want to help people kind of develop the capacity to kind of evaluate that and evaluate it with us. Or we want to support people in figuring it out. In what ways is it helpful and in what ways is it problematic? So that we could say that, an addictive relationship may be using a substance in a problematic way, that has sort of a compulsive element in that a person has difficulty kind of pulling it back. But it's more complex than that, because I think often the problematic aspect of it also is serving something that needs to be understood. But I think that we might all agree that kind of as we begin to think about moving on a spectrum toward addiction, it's defined by problematic aspects of use that a person can't rein in or can't control or make healthy choices about.
Julie always mentions the adverse consequences of using an illegal drug and the adrenaline rush caused by, because I don't want to divorce these issues from the context of using something that's prohibited, the contraband. And, what is the rush of using something on the sly, and how does that contribute to a problematic use pattern? Or what if that is what if it's because of the policy that you're using it problematically, and really if it was illegal, if you were in Holland or some other place, then whatever problem around snooping around or sneaking use. I'm just kind of throwing out some questions to complicate it a little bit.
Yeah, I definitely think that one aspect of addiction for many of my patients is that there's an element of lying and hiding and shame. And all of that adds to the adrenaline, but it also makes you uncomfortable and feel like you need more drugs to quell that. And so I think one of the advantages to having decriminalization or legalization is that you don't have, the example I always give is like if I have dinner with my kids and I have a glass of wine and my husband has a beer and I have some, but I leave half the glass there because I don't really like the way it tastes, whatever. But my kids can see, my relationship with alcohol, and I can model sort of healthy behavior for them. But we don't have that option with cannabis. We have to, the kids hide it from the parents hide it from the kids. Nobody's modeling healthy behavior. And there's all this hiding and lying and shame and guilt, which ends up making it more adrenaline charged, which makes it more addictive, and also more shameful, which makes it feel worse, which makes people sort of, have to be more compelled in finding other ways to quell their anxiety. So my sense is that, what I always say is our government's turning us into junkies. Our drug policy is definitely making our behavior worse, not better. And in countries where they have legalization, they have lower teenage levels of use. Because the kids, if it's legal, there's a lot less appeal. You tell your kids you can't have that cookie on the high shelf, that's all they want. If you leave the cookies out, but you also have some cherries out, they'll go for the cherries. If everything's there, they won't hide it and sneak it and feel bad about it. And, it's a whole different behavior. So I think that's part of addiction.
So the way that I frame that is in terms of a paradigm shift in the way that we think about misuse or addiction from this old disease model, which, is sort of this self-propelling model that it's all about this sort of toxic problem that's contained within the individual, that is self-propelling, it's progressive, it's chronic, etc. What I think Julie is alluding to is we're moving toward what I call a psychobiosocial spiritual model. That is the idea that addictive behavior or problematic use it reflects these multiple currents of biology, psychology, social context, culture, meaning, habit, which converge and get played out around the problematic use. So that in the old disease model, the lying was part and parcel of the disease. I think what she's implying is that actually the lying is and the anxiety and the guilt and the shame are in part a reflection of a social context that criminalizes and stigmatizes drug use, such that, let's say, the person who finds it an essential way of managing post-traumatic stress symptoms and anxiety, like my patient, now has to use an illicit substance and worry about getting arrested and losing her kids, so now she's going to hide it. But then that just informs, it contributes to a worsening of or intensification.
So it becomes denial, and you're lying, and
Right. Without really seeing it in the broader context of what's happening in the relationship, in the social context, and so on.
Thank you. You and then you. Oh.
Hi. I know that a lot of physicians, when they do administer pain medications, they're very, very cautious these days with all the restrictions placed on them, feeling like they're being watched by the government, having to report pain medications that they prescribe on their licenses. And as a psychologist, I've noticed that a lot of doctors are just very, nope, you're becoming addicted, so I can't do this, I can't do this. Some patients are not very amenable to non-pharmaceutical interventions such as mindfulness, what have you. And I was wondering if there have been studies on tolerance levels, shifts in tolerance levels for pain management when marijuana is prescribed for medicinal purposes.
Yes, there's minimal tolerance compared to opiates, especially when CBD can be given for years with no tolerance, and I think THC is pretty minimal. You back me up here, Sunil?
Yeah, exactly. The tolerance, I mean, there does exist, there's going to be some downregulation of receptors over long-term use of exogenous cannabinoids. Your cannabinoid system can kind of like reduce. And in some cases, the interesting thing is if you take drug holidays, if you stop or slow down, you can actually return or have a more potent effect when you return. And some of these physicians, like in Maine, I have a colleague up there who's been using cannabis in his practice. He's a family doc osteopath, and he's been really educating his patients on trying to minimize the amount of use for their various chronic pain issues. Try to use less, as little as you need, because you'll get more bang for your buck. And it turns out the endocannabinoid system is pretty powerful, and you can actually feed it, and care for it, like you care for your other, it's kind of like a preventative health kind of model.
Right.
So CBD actually does boost the activity of your endogenous cannabinoid system. So that's kind of things to think about. Tolerance it takes into a factor the body's adaptation. So that's why I'm describing that.
But not only that, but if I understand correctly, tolerance for analgesia is lower than tolerance for euphoria across all sort of psychoactive substances.
Tolerance for analgesia is less than tolerance for euphoria. Well, you can get high if you like a lot of.
In other words, you need to increase the dose to achieve euphoria at a more rapid rate than you would to experience pain relief.
Oh, okay. I don't do a lot of dosing for euphoria, so or at least at the, so I've less. With my patients, so I've less sort of experience back and forth rapid feedback on that, and less education on that. So I'm glad that So it's interesting to think about. But I do know that in patients who have severe pain, especially cancer pain, all bets are off. Like the dose ceiling, you can go really high if you to achieve the effect, and you should keep going up until you achieve the pain relief in some of those severe pain cases. And cannabinoids and opioids act in a very interesting way together. So
Right, yeah, you could tell I'm chomping at the bit. One thing that's important that we hear over and over from people who are prescribing is that patients who are taking medicinal cannabis can lower their doses of opiates, and that's good. They're synergistic. They seem to work their special little magic together, and so pot allows you to take less Percocet, and that's good.
1 and 2, and then 3. And I think that's all we'll have time for.
If I may, I'd just like to get back to the law that we were talking about. And it's very difficult. You have to be careful about generalizing about what physicians do or don't do in terms of over or under prescribing. However, 10, 15 years ago, physicians were accused of undertreating pain, afraid of iatrogenic addiction. As there was a shift, it moved over to overprescribing. And while there are certainly people who are cautious about it, we run into a lot of people who are getting too many medications, huge prescriptions. So when I look at the law, it appears to me that, well, I was asked to come down here by people who are concerned about how this marijuana is going to spread it among young people. And so I looked at the law to look for what loophole there might be. And it appears to me that it's the physician who is the loophole in this whole bill, physician or PA or NP. And
Can you read, tell us what you're referring to?
If you read the bill, after it indicates all the serious conditions, then it finishes with, or a condition associated with, or a complication of such condition, or its treatment, including but not limited to inability to tolerate food, nausea, vomiting, dysphoria, etc. Anxiety can be thrown in there. Someone can come in with anxiety and the physician may feel, well, I've got to help this person. There have been concerns about the advertising of drugs on television and how that has influenced the physician to respond to a request by the patient. So,
Who asked you to come down here? You said you were asked to come down here. I was just curious, like.
I wear several hats. I'm co-chairman of the police commission in Greenburgh, New York. I work with a committee in Ardsley, which is a community in Westchester that is concerned about safe families, and we've all been working on underage drinking, and marijuana slips into that as well as cocaine and so on. So when they heard about this, they just started laughing and saying, well, this is just an excuse to get marijuana legalized. Mm-hmm. And I think medical marijuana is a valuable contribution to helping people. But I think the problem is going to be with how the physicians decide to prescribe this, and I think it's going to get very loose. Perhaps we'll get to a point where, as you were saying before, when it's legal long enough, it may lose some of its attractiveness. Mm-hmm. But I think we're going to go through a serious dip.
I'll just speak to a couple of facts. Since I worked in a medical marijuana state, so it was legal since 1998. I went to medical school in Washington State, and I did research with physicians who were using cannabis in their practice. In Washington State, we had a list of 10 qualifying conditions, right? And so that was sort of how it was gate kept. And physicians, if you wanted to add an additional condition, you go to the Department of Health, then you write a petition. I actually petitioned to get neuropathic pain added to it. They rejected the petition because before that it was intractable pain, and that means you had to fail a bunch of treatments. And I thought, well, neuropathic pain, nerve pain, people can get better right away with cannabis. So the research is there. But then they decided to add dialysis-related fatigue, even though we don't have a lot of studies on patients on dialysis. But the patient made an impassioned plea to the board who had dialysis, and they had a nephrologist there. And now, dialysis is now a condition that's been added to the law. So there's negotiated space with the Department of Health of the state of Washington and physicians and patients where they would use a petition process, added conditions to the law. The latest version of this bill, my understanding, is there's a list of enumerated debilitating conditions, and then if you want to add additional ones, the New York State Department of Health becomes a place where that negotiation occurs. So there is some process of health officials sort of balancing the risks as you're talking about, so it doesn't get this overly broad. In California, when they passed in '96, they said, and any other condition for which marijuana provides relief. It was a 5 or 6 word statement added by a psychiatrist, Dr. McCurry, which is the same way, by the way, we prescribe everything else. There's really nothing else but because of the politics and the issues around the social issues, so and back there, that's sort of how it went, and we have 250, 300,000 patients using cannabis and medicinally in California. Whereas in these other states, which have more defined condition lists, it's a smaller number. You should be rest assured that the research done by Brown University, they've looked at the numbers, if there's increased teen use, adolescence use, pre and post medical marijuana in all these 18 states, and they actually have seen dips in these numbers. It is, I think, probably a de-glamorization phenomenon, as Dr. Tatarsky talked about. So those issues are part of the discussion, but definitely gatekeeping is a tough role to be in. But I think what physicians and PAs and NPs go through training to kind of make those risk-benefit decisions, and there is a lot of surveillance and watching on this thing. So hopefully, the benefits will outweigh those risks.
Thank you.
That's good. You should vote on that question.
Yes.
Okay. First to self-correct, I looked at the law very briefly earlier, and I believe I misread it. 21. It's hard to be a caregiver if you're under 21, but not impossible, and pretty much anyone of any age can get the drug. I'm wondering, I believe also the way the law is written now, that physicians' assistants, and RNs are able to register patients.
NPs, not RNs, advanced registered nurse practitioners.
Nurse practitioners. So either way, I'm wondering if you can comment a bit if there's any ethical, legal, or licensing issues that comes with what is essentially prescribing a non-FDA approved drug?
No, because it's not prescribing. A prescription has to be written on a prescription pad and signed. That's a prescription. You write a sig, a dose, you sign it, take it to a pharmacy. This is a medical authorization. This is like, are you okay to go bungee jumping now that you've finished your training? Okay. Are you okay to like play sports now that you've healed from your fracture? Are you okay to return to work? Do you have a medical necessity to get this thing covered by insurance? These are other things that doctors routinely do, which aren't the power of the prescription pad. And this isn't a workaround, the federal prohibition Schedule 1, which the government says. Now, there are people prescribed marijuana in those clinical trials. You have to get a license, Schedule 1 prescriber license, and you get a prescription, and the government fills it for you. But this is an authorization. So, and in all the Conant decision, the Supreme Court decided it in a few years ago, I can't remember what year, they said basically it's a First Amendment free speech issue, and you're allowed to counsel the patient, discuss whatever you like, and so that's protected. And the Supreme Court chose not to overturn that decision of the Ninth Circuit. It's called Conant versus Walters. So that's the kind of legal theory behind which medical marijuana authorizations, of which maybe 10,000 physicians have participated in various programs, and nobody has brought the license issues occur because of malpractice. People not writing their, not doing proper workup, just typical disciplinary issues that happen, pill mill style stuff.
Just one thing to note. I think it's in the interest of precision. It's not correct to say that kids can get it, because if they're a young person, they can get access, but it has to be with parental permission. And so this has happened in other parts of the country, in places where the physician has believed that the young person who's under the legal age of adulthood would benefit through a course of the use of medical marijuana, and they have to get the signature of the parent to be able to recommend it to them.
Thank you.
Yeah, there's pediatric palliative cases. The hospitals are full of them, so it's an important class of patients that we should take care of. But obviously, additional safeguards are needed.
We'll take a final question.
Quick question. Are you aware of any evidence that medical marijuana is helpful for medication-resistant migraine?
Yes, sir. Yeah, the doctor who first wrote about that was the father of internal medicine, William Osler. He's founded Rounding at Johns Hopkins. And anyway, in his first book of internal medicine, he said cannabis is probably the most superior treatment for migraines. And he was actually quoting from a New York neurologist in those days who was the president of the New York City Neurological Association. I've forgotten his name now. But anyway, there's a long history of cannabis use in the treatment of migraines by our luminaries in medicine throughout the 20th century. And I know one physician who tried to do a clinical study, a more modern study, but he was blocked by the government monopoly on research, unfortunately, and they didn't allow him to do it. So he went into the private industry and has been doing research with the cannabis extractions, with private companies, but they haven't looked at migraines more recently. But there are some really interesting, promising research in pain, and I'll refer you to my website, cannabinergy.com. I have some articles on pain management, and you can look at the headache stuff there.
Andrew, you want to weigh in?
Yeah, if I wanted to follow up that question with another question to, I guess, these folks. I don't know how much time we have left, but
We're there.
okay. I'm just very interested in what the thinking is about the use of cannabis for the treatment of psychiatric issues like anxiety and depression and PTSD, and both from a research standpoint, but also from a policy and procedure standpoint, since it seems like all of that is being specifically excluded from the bill.
Dr. Holland, do you want to?
There's a pretty high percentage of patients in California that are using medicinal cannabis for psychiatric complaints, primarily depression, insomnia, and post-traumatic stress disorder, sort of in that descending order. But most of the bills don't say anything about psychiatric disorders. I think Alabama. Does Alabama have medicinal? It's like, no. There's some.
Actually, New Mexico,
Arkansas?
New Mexico, Connecticut, and there's a third state, Delaware, all have PTSD listed in their qualifying condition list. In New Mexico, PTSD patients are the predominant class of patients using cannabis from state licensed dispensaries.
But it's important to note that in New Mexico, the biggest group of patients who have PTSD that are using medical marijuana are veterans. And Oregon actually just passed a bill today that is going to the governor's desk now, is expected to be signed, that adds PTSD as a qualifying condition under the Oregon law. In New York, it's not in the condition, but there's a lot of discussion, particularly amongst veterans groups, about this specific issue. And with 2.5 million Americans having served in Afghanistan and Iraq, it's one that we're going to be faced with as troops are coming home from these very long wars. And PTSD is a real big issue with a lot of the vets. There's a number of vets working on this issue here in New York who are advocating for just this thing, but around the country. And in New Mexico, it was a veterans group that actually led the effort to keep PTSD in the medical marijuana program there, because they were the amongst the largest patient groups there to be utilizing it.
So a final word from all of our panelists. I would ask you, best case, worst case scenario, if this bill were to pass. As a
my patients don't have to break the law to try a medication that's less toxic than what they're already taking.
Best case scenario, this bill passes, becomes signed, and New York becomes the 20th medical cannabis state, and we'll have another option for patients with debilitating symptoms. I mean, less deaths from opioids from people who would, this medicine can't kill you. And there'll be more education of healthcare providers and all around, and I think that's what you want to do with something that has this much potential, is educate and try it out.
No one's touching the worst case scenario. Then.
Worst case scenario.
Leave it on a good note is nice.
Huh?
So leave it on a positive note is nice.
Complete, utter chaos and mayhem, worst case scenario.
I think that the shame and anxiety and guilt that most people with substance use problems struggle with is further contaminated by the stigma and criminalization, and that to clear that out of the way, at least, to open a conversation about, whether this is a proper use of a medication, kind of clears something that may help us as clinicians to address that with patients in a more effective way.
I mean, in an immediate sense, I think of the patients that we work with, people like Beverly from the Hudson Valley, or Susan from Rochester, or Joel from outside of Buffalo, who are all living with a variety of conditions. Beverly in particular is living with stage 3 cancer, and is very clear that she's moving towards her death, and is very wide-eyed about that. And medical marijuana provides her a great deal of relief. And being with her in Albany as she's talking to legislators and saying, basically, I'm dying. I would like some sense of relief here where I don't have to go to the criminal market in order to obtain the marijuana. I'd like to have it tested. I'd like to be able to talk to my doctor about it. I think the best case scenario is that Beverly and folks like her are no longer criminalized for trying to seek relief, and the folks like the panelists here are able to talk with their patients about this as a potential course of treatment without fear of criminalization, without fear of whether or not they're going to get in trouble, and with an openness that there's a legal regulated place where their patients can go and obtain this stuff that's not Washington Square Park in the dead of night.
Thank you.